As I mentioned, I'm going to talk about the different types of head and neck cancers and thyroid cancers, and I'll review the basics: anatomy, epidemiology, diagnosis, staging, and clinical presentation. I'll also spend a little bit of time talking about HPV and oropharyngeal squamous cell carcinoma and the management of head and neck cancers and thyroid cancers. So first, again, I'll talk about head and neck cancer. And the anatomy is very important when you're discussing head and neck cancers, because essentially what I always tell whoever's in clinic with me is you can have a cancer of anything in the head and neck. So obviously up here is the nasal cavity. We see nasal cavity cancers. Back here is the nasopharynx. You can have a nasopharynx cancer. The oral cavity makes up the anterior 2/3 of the tongue, the floor of mouth, the lips, the hard palate, and the gums. We see salivary gland cancers of the gums. We see sinus, maxillary sinus cancers, ethmoid sinus cancers, sphenoid sinus cancers. And then back here, probably the most common and the most important for an internist, whether or not you're taking the boards or staying an internist, is the oropharynx cancers. The oropharynx is made up of the soft palate, the tonsils, and the base of tongue. And these are the cancers that are associated with HPV. And then finally, down here, you have the hypopharynx that I call the food tube, and the larynx, which is the air tube. And based on where these tumors are, the treatment is going to be different. So today I'll really only talk about squamous cell carcinoma of the head and neck, and I'll include nasopharyngeal carcinoma, which is actually separate. But there are many other types of head and neck cancers, as I mentioned, salivary gland malignancies, of which there can be any number of types, such as adenocarcinoma, adenoid cystic, mucoepidermoid, etc. There are other rare paranasal and other sinus cancers, such as esthesioneuroblastoma, sinonasal undifferentiated carcinoma, and sarcomas. You can also have lymphomas of the head and neck. I'm not talking about those today, and thyroid malignancies, which I'll talk about in a little bit. This is just a slide of the epidemiology worldwide of head and neck cancer, and the variance is really based on risk factors. And across the world, the male to female ratio is anywhere from 2 to 4 to 1. So this is a more common type of cancer in males than females. And you'll see that the prevalence is higher in countries where there's known to be a history of tobacco smoking, but also betel nut chewing is a risk factor. It makes your teeth look like this, so I don't recommend it. Also, it can give you oral cavity cancer. But you'll see here Papua New Guinea has a very high rate, and it's one of the risk factors we'll discuss. So the epidemiology, the cancers, according to the SEER database, are divided into oral cavity and pharynx and larynx. This isn't really the best division because oral cavity is the oral tongue and the lip, and those are smoking cancers, and most of the oropharynx cancers nowadays are actually HPV related and have a much better prognosis. But overall, in 2019, there were 53,000 new cases of oral cavity and pharynx cancer and roughly 12,000 cases of larynx cancer. So as you can see, they don't make up a large percentage of cancers in the US, really only 4% or so, and so overall considered a rare cancer as far as cancers are concerned. But if you look here, the oral cavity and pharynx incidence is rising, and that of course is reflected by the incidence of HPV related cancers of the oropharynx that are going up. And if you look down here, larynx cancer, fortunately, is decreasing in incidence, and that's because it's a smoking-related cancer. So the smoking-related head and neck cancers are going down in incidence, whereas the HPV-related cancers are going up in incidence. So what are the risk factors for head and neck cancer, squamous cell head and neck cancer? I sort of mentioned tobacco is really the big one that we think of. There's anywhere from a 5 to 25-fold increased risk in cigarette smokers. Alcohol as well, it's dose dependent and has a multiplicative relationship with smoking. So you see here the smoking circle, if you add in an alcohol by itself, a 10 times increased risk, but if you add them together, it's 22 times. Viral infection, of course, we'll talk about HPV-related oropharynx cancer. EBV virus actually causes nasopharyngeal cancer, and HIV infection results in an increase in all types of squamous cell cancer, skin and head and neck squamous cell cancer. Betel nut chewing, which is not very common here, but is widespread in parts of Asia, is a very big risk factor, and it's again synergistic with alcohol and tobacco. So you see here, betel nut is a very strong risk factor for primarily oral cavity cancers. But if you add in alcohol and tobacco, the risk is 123 times greater. There's some occupational exposures. Agent Orange has been associated with base of tongue and larynx cancer, formaldehyde, radiation exposure, and some genetic syndromes like Fanconi anemia. So just a little bit about HPV virus. As you know, it's a DNA virus that infects the skin and mucosa. It causes genital warts and other anogenital lesions, as well as malignancies, including head and neck cancer, caused by types 16 and 18 primarily, which also cause cervix cancer. And I think this table is interesting. If you look at how many cancers are linked with HPV each year.com, you can see that in back of throat, which is oropharynx, about 2,200 cases in women and far more in men, which really doesn't make any sense because you know, you would expect that it would be closer to even. And obviously cervix cancer, most women who are infected with HPV are getting cervical cancer rather than oropharyngeal cancer. And then you can see the numbers of anal cancer, vulvar, penile, and vaginal cancer. So back in 2000, late 90s, people started noticing that there were increasing cases of oropharynx cancer, of head and neck cancers in younger Caucasian non-smoking males with a history of marijuana intake and multiple sex partners and oral sex. And Gillison et al., she was at Hopkins at the time, reported PCR detection of HPV DNA within the oropharynx cancer. These tumors are primarily at the tonsil and base of tongue, but can be found on the soft palate and posterior pharyngeal wall. They have a very high predilection for nodal spread. Fortunately, they're very responsive to all treatments, and now they make up about 70% of oropharynx cancer, and the incidence is rising. So just a little bit about HPV carcinogenesis. So what happens is the HPV virus infects the cell, elaborating these two proteins. The EBV-associated proteins are E6 and E7, and you can actually do an assay, a PCR assay for E6 and E7 to absolutely confirm HPV infection in the cell. And E6 binds to P53 and promotes its destruction. E7 inactivates retinoblastoma gene, and what ends up happening is you have an increase in accumulation of the P16 protein in the cell. So people get confused because HPV 16 and 18 cause cancers, but what you're actually seeing is an increased level of P16 protein. So the P16 protein stain, or immunohistochemistry, correlates with HPV infected cells or HPV related oropharynx cancer and cervix cancer, but not with other types of head and neck cancers. So as I mentioned, the cases of HPV related oropharynx cancers are high. It counteracts normal apoptosis, whereas HPV negative tumors are caused by tobacco and alcohol and result in a P53 mutation, which actually causes decreased expression of the P16 protein. So what about vaccination? The thing with head and neck cancers and oropharynx cancers is that regulatory agencies have required a clinical disease endpoint, such as a precancer, like you see with cervix cancers, for trials of the HPV vaccine efficacy in cancer prevention. And unfortunately, we're not able to detect precancer lesions for HPV positive oropharynx cancers. So there are no clinical trials to show that the HPV vaccine reduces the incidence of HPV-related oropharynx cancer. But we do expect to see a decrease in the incidence of HPV-related cancers probably after 2060, because the infection, the cells take about 30 years on average to become cancerous. And so people are infected usually in their early 20s, and then they get the cancer in their 50s and 60s. We do know that vaccination does reduce oral HPV infection from the NHANES study that looked at males aged 18 to 33. And based on that data and the assumption that if you can reduce HPV oral cavity infection, that you'll reduce the incidence of oropharynx related cancer, Gardasil 9 was approved for men and women age 45 and younger. So I mentioned oropharynx cancers. I just want to be clear. I've probably said it already 10 times, but the oropharynx is the soft palate, uvula, the tonsils, and then back here, the base of tongue. Whereas oral cavity cancers are going to be the body of the tongue, the floor of mouth, which is under the tongue, the retromolar trigone, the hard palate, the teeth, so anything up here. So the clinical presentation of head and neck cancers really varies depending on the risk factors and site. So for oropharynx cancers, these HPV-related cancers will often present with cystic neck masses. So if you see, in particular on a test, a white male in his late 50s, early 60s, then and it has a neck mass, it doesn't get better with antibiotics, it's probably an HPV-related malignancy. The patients will often have large lymph nodes that get misdiagnosed as cysts. Sometimes they can have dysphagia or pain, sometimes otalgia radiating up into the ear, snoring or bleeding. Larynx cancer often presents with hoarseness and then dysphagia, sometimes pain, cough, hemoptysis. Oral cavity cancer, you'll have mouth pain or non-healing ulcer, ill-fitting dentures, pain and dysarthria. Up to 66% of oral cavity cancers will have lymph nodes. And nasopharyngeal cancer also tends to present with neck masses in most patients. They can also have hearing loss, tinnitus, or nasal obstruction and pain. At Georgetown just last week, a patient was admitted with a brand new nasopharyngeal cancer. She actually presented with vision loss. So, you know, it's back here, close to the optic nerve. Hers was 5.5 centimeters. There's not a lot of room for a big tumor back there. So you can certainly present with headaches and vision loss as well. So just a little about the diagnosis and staging. The initial exam should be done by ENT and should include history, indirect mirror exam, and flexible laryngoscopy. Obviously, a base of tongue tumor back here can't be seen when you have someone say ah, so you really need to stick that tube down there with the camera and see what's going on. Obviously, if there's a history of heavy alcohol and tobacco use, you need to look for a second primary, either by endoscopy or PET or both. In patients who have a high pack year smoking history, we'll often see 2 head and neck primaries. I mean, I shouldn't say often, but it happens. Patients can also have a lung primary or esophagus. The most common sites for metastatic disease are lungs, liver, and bone. And so imaging of all patients should include a neck CT or MRI of the head and neck, and probably a PET scan to look for distant metastatic disease. Biopsy should be done, either FNA or excisional biopsy. So the staging differs for each tumor type, and I won't subject you to the staging because it's just long and exhaustive, but the HPV-related oropharynx cancers have such a better prognosis that it's led to a new staging system. So this is the staging, the old staging system, which included the staging for and still includes the staging for HPV negative cancer. So you can see here that if you have a small tumor T1 with no lymph nodes involved, you're stage 1. Large tumor with a very large lymph node is stage 4B. 4B regardless is considered, T4B regardless is considered stage 4B. But when it was broken down by survival for HPV positive patients, really stage 1, 2, 3, and 4A all had the same survival. So now HPV-related cancers has its own stage, which really does nothing other than confuse people, because now you have locally advanced disease where it used to be called 4A, it's called stage 1. So it's just confusing, but basically all locally advanced head and neck cancers are treated the same, regardless of whether or not it's now called stage 1 or 4A. So stage 1 or 2 is typically limited to the primary site, again, except for HPV-associated oropharynx cancer. And stage 3 or 4 involves locally invasive tumors like big tumors or very invasive tumors, or with nodal involvement. And so those are going to be the patients that I primarily treat. So stage 4C is distant disease. These are what you consider incurable. 4A and 4B are still locally advanced curable patients. So not all stage 4 is incurable. It really depends on the tumor type. So when my patients with stage 4A get admitted for feeding tube placement and pain control with mucositis, it's not because I'm a cruel, evil person torturing them. It's because I'm trying to cure their cancer. So the prognosis differs based on the tumor type. Again, the earlier the cancer is found, the better the prognosis is. Distant metastatic disease obviously has a worse prognosis in oral cavity, oropharynx, and as well as larynx. You can look at HPV status to see what the prognosis is for the patient and take into account the pack year smoking history. So one of the original studies that was done with radiation looked at 266 patients with oropharynx cancer who had known HPV status and known number of pack years smoking. And they broke them down into HPV positive and HPV negative tumors, and then looked at pack years of smoking. So if you have a HPV positive tumor with less than 10 pack years of smoking, you're considered low risk and therefore would have a very good survival of up to 93% at 5 years. If you're HPV positive and you have at least a 10 pack year smoking history, if you have very limited node disease, then you still will be considered low risk. But if you've got more involved, this is just bilateral lymph node involvement, then or multiple unilateral lymph nodes, then you're considered intermediate risk. HPV negative tumor patients who have a heavy pack year smoking have by far the worst prognosis. So you can see how the prognosis, depending on whether or not it's HPV positive and smoking, can really vary. So what about the pathogenesis? There's this field cancerization effect where repeated exposure to tobacco and alcohol really prime the entire upper aerodigestive tract for multiple primaries by damaging the mucosa, and as I mentioned, HPV. So treatment of head and neck cancers, essentially early stage disease, stage 1 or 2, is usually treated with either primary surgery or definitive radiation therapy alone, and they have good survival, 5-year survival of 70 to 90%. As I mentioned, I treat primarily the local regionally advanced disease that would be stage 3 or 4A or 4B, and that's treated with a multimodality approach. So it really depends on the location of the tumor, functional outcomes, et cetera, which is why it really needs to be reviewed by an entire multidisciplinary group. So some patients will have surgery followed by postoperative radiation or concurrent chemoradiation. Some will have concurrent chemoradiation without surgery. Some will have sequential therapy consisting of chemotherapy first, followed by concurrent radiotherapy without surgery. So there are a variety of different ways patients can be treated and really need a center that treats a lot of these patients and that has multidisciplinary input. So first I'll start with the larynx and hypopharynx. It's important to think about the goals of treatment. So obviously we want to cure the patient and we want them to survive, but also organ preservation and the ability to eat and breathe and speak are very important, as our quality of life. So for locally advanced larynx cancer, the physical and psychosocial impact of a permanent tracheostomy and loss of voice are very powerful drivers for patients to want larynx preservation. But the patient selection is key. So if you have a very advanced tumor that's already destroying the cartilage or already has fixed vocal cord, then they weren't eligible for larynx preservation trials, and those patients should proceed to laryngectomy. Hypopharynx cancer, the food tube has a worse prognosis. They have high rates of metastases because of where the lymphatics drain, a very poor ability to salvage late recurrence, and obviously, since it's the food tube, you have a very high risk of pharyngeal dysfunction and need for a PEG tube. But there was a trial that looked at trying to preserve the larynx and hypopharynx, and they randomized patients to chemotherapy, and if they had a good response, they got more chemotherapy followed by radiation. If they had no response, they just had surgery followed by radiation. They were the other group was chemotherapy at the same time as radiation, and the final group was radiation alone. And this is laryngeal preservation % of patients, and what you can see here is that getting radiation with concurrent cisplatin resulted in laryngeal preservation in 84% of patients, compared to 67% with radiation alone and 72% with chemotherapy followed by radiation. So only 16% of patients needed a total laryngectomy if they were treated with concurrent chemoradiation. So that's how it became the standard of care. And if you look at long-term, this would be a 10-year survival. The chemoradiation arm continued to be superior as far as laryngeal preservation, but overall survival really didn't differ, and in fact might have favored actually chemo followed by radiation. I never know what to make of in overall survival when you're looking at cancers that are caused by smoking and alcohol, et cetera, because I assume that these patients are going to have significant comorbidities, but the concurrent chemoradiation did have the highest rate of non-cancer related deaths. So the standard of care is typically chemoradiation for larynx and hypopharynx preservation, but if there's a large tumor that's complete cartilage invasion or fixed vocal cords, then the patients should typically have a primary laryngectomy. So oropharynx cancer, there are very few randomized trials comparing the efficacy of surgery with adjuvant chemoradiation or chemoradiation alone. There was a big trial that was underpowered, but the typical treatment will be chemoradiation if the tumor is causing functional problems, if there's bulky lymph nodes, or if it's not easily resectable with transoral robotic surgery. This is just a meta-analysis that showed that adding chemotherapy to radiation improved cure rates or mortality by about 6.5% at 5 years. And then more recently, there were 2 studies, one done in the UK and one done in the US, looking at patients with HPV positive cancer and whether or not you could replace cisplatin with cetuximab, which is approved for head and neck cancers, thinking that cetuximab might be as effective and less toxic. And what both of these, these trials both showed was that the cure rates were lower with cetuximab, so overall survival at 5 years was 78% versus 85%. As was local regional failure was worse with cetuximab, distant metastases. The acute toxicity was worse with cisplatin, but late toxicity was not. And that's just the survival curve. So for locally advanced oropharynx cancer, the standard of care is cisplatin with radiation. I'll go briefly to oral cavity cancer. Surgery is the preferred treatment for early stage and locally advanced oral cavity. So really anything in front of this line here, you typically will do surgery. And that's because if you give it too much radiation, there's a lot of important bones here, and the doses of radiation required to cure the cancer will cause high rates of osteoradionecrosis. Margin status is important. Local regional control is significantly improved with larger margins of at least 5 millimeters. And for locally advanced disease with a lot of risk factors, radiation is standard of care following surgery. Sometimes we'll add in chemo, but I won't get into that. The last type of head and neck cancer that I want to talk about before I move on to thyroid cancer is nasopharyngeal carcinoma. That's because this one is associated with the EBV virus. It's endemic in southern China, where the incidence is 30 per 100,000 people. It's very radiosensitive and chemosensitive. The primary treatment is radiation therapy with or without chemotherapy. So for stage 1 disease, you can give radiation alone. Stage 2 is usually radiation with chemotherapy or sometimes without. And stage 3B or 3 to 4B will be typically chemoradiation. Sometimes we'll give induction chemotherapy first, so chemotherapy followed by chemoradiation. And then surgery, you can see there's not a lot of room to operate back here in the nasopharynx. So surgery is typically reserved for patients who don't have a complete response to chemo or chemoradiation. So this is the worldwide incidence. So you can see this is men and this is women. So as you see here, the cases are much higher in parts of Southeast Asia, including Indonesia. Over here, this is part of Indonesia, Papua, and this is Papua New Guinea. So Papua New Guinea is where they chew the betel nut and have the squamous cell cancers, and then Papua is part of Indonesia where they have high rates of nasopharyngeal cancer. And then lower rates in women, but the same sort of distribution. Also Western Africa. I've had patients from Africa, China, Korea, Japan, and then I sometimes will have EBV-related cancer patients from the US as well. The EBV level is prognostic. So this patient who was admitted last week, I still don't know if anyone actually drew the EBV level, but hopefully they did. The pre-treatment EBV level is associated with prognosis. So overall survival is worse for an EBV quantitative PCR level of at least 1,500 copies, and is better if it's less than 1,500 copies. And it's also important to check 1 week post-treatment after they finish everything, chemoradiation. If it's undetectable, the overall survival is much better than detectable levels. As I mentioned, radiation for early stage disease, concurrent chemotherapy, or induction chemotherapy alone. So I'm not going to talk about recurrent metastatic disease today because we're talking about thyroid cancer next, but essentially immunotherapy and chemotherapy are the options unless there's some local therapy that can be done that is potentially curative. So next I'll talk about thyroid cancer, and that encompasses the differentiated thyroid cancers, which are by far the most common, papillary and follicular being the most common of those, anaplastic thyroid cancer, and medullary thyroid cancer. So just to review the thyroid histology, because the cancers derive from the different cells that make up the thyroid follicles. So the follicular cells that outline the colloid here are stimulated by TSH to convert thyroglobulin to T4. And the parafollicular cells synthesize calcitonin, and then the colloid is the storage material for the thyroglobulin. So you have tumors, cancers of the follicular epithelial cells, and you can have cancers of the parafollicular or C cells. So cancers of the follicular, which are the normal thyroid cells that result in thyroid function, are differentiated thyroid cancer, poorly differentiated thyroid cancer, and then undifferentiated. Differentiated being primarily papillary thyroid cancer with occasional Hürthle cell and follicular thyroid cancer. Poorly differentiated, which are probably derived from follicular or papillary thyroid cancers, and then the undifferentiated, which is anaplastic. And then the cancer of the parafollicular or C cells is medullary thyroid cancer. So thyroid cancer is the most common endocrine malignancy, and it has an excellent prognosis overall. You can see here the 5-year survival is 98%. The cases are about 52,000 a year, death rate around 2,100 estimated in 2019. So, everyone says if you're going to get a cancer, you should get thyroid cancer because of the excellent prognosis. But of course, we do see patients who aren't in this high percentage at 5 years or perhaps 10 years or 20 years. It can be very slow growing. So the age and gender adjusted incidence has increased faster than that of any other malignancy, and no one's really sure why. When I first started studying thyroid cancer back in 2005 or 6, 4, there were 23,000 cases per year, and then in 2016 it really jumped to 64,000. Now it seems to be leveling out a little bit more, 52,000 in 2019, and because of this high incidence, the prevalence is also high and increasing. So here you see the SEER incidence, thyroid cancer is at the top, and also the death rate has been increasing, and no one's exactly sure why this is. This is just a table of the prevalence of the different subtypes of thyroid cancer. As you can see here, papillary thyroid cancer is by far the most common. It presents at a relatively young age 20 to 50. Follicular thyroid cancer is about 10% or less, a little bit older age for patients, but still with an excellent prognosis, sometimes higher rate of distant metastases. And then poorly differentiated is worse than well differentiated, but not as bad as undifferentiated, which is anaplastic thyroid cancer. Fortunately, very rare, but with a very poor survival rate, occurs at an older age. And then medullary thyroid cancer is also rare, 3% or so of thyroid cancers occurs typically ages 30 to 60 with a prognosis that varies. So the staging of thyroid cancer is really weird. It includes age in the differentiated thyroid cancers. I believe it's the only cancer staging system that includes age. And that's because if you're under the age of 55, if you have thyroid cancer, even if it's metastatic, you're still only considered stage 2 because the prognosis is so good. So the highest stage you can be if you're under the age of 55 is stage 2. Whereas the staging for patients who are at least 55 years of age is more typical. Medullary thyroid cancer is pretty typical staging, kind of boring. But then if you look again at anaplastic, no matter what, even if you just have a little FNA with a tiny tumor in your thyroid and it says anaplastic thyroid cancer, you're automatically stage 4A. This cancer has such a poor prognosis that all patients are considered stage 4, 4A, 4B, or 4C if they have distant mets. This is just a table to show that by and large, most of this big series of patients, 43,000, are going to have papillary thyroid cancer, and half of them are going to be really early stage disease, stage 1 or stage 2. Thyroid cancer signaling is pretty interesting. There are a variety of activating mutations and fusions that result in thyroid cancer proliferation, survival, and growth. And the new therapy new therapeutic agents that have been developed in an attempt to interrupt these signaling pathways. So for medullary thyroid cancer, 100% of hereditary, or I mean, of course, there are always exceptions, but nearly 100% of hereditary medullary thyroid cancer is actually caused by a germline activating RET tyrosine kinase mutation. And about 40 to 60% of sporadic medullary thyroid cancer harbors a somatic RET mutation. And interestingly, up to 25% of papillary thyroid cancers have a RET fusion that results in the pathogenesis of their malignancy. There are also TRAC fusions or N-TRAC fusions in thyroid cancer, in papillary thyroid cancers. I have here, it says 5 to 15%, and I think that the incidence is probably higher in other parts of the world. In the US, it's more like 1%. There are also mutations in the RAS oncogene in medullary thyroid cancer, lesser so in papillary thyroid cancer, 25% of follicular thyroid cancer, and 25% of anaplastic. And then about half or maybe more of papillary thyroid cancers will have a BRAF V600E activating mutation. About 25% of anaplastic thyroid cancers will also have a BRAF activating mutation. And then the follicular thyroid cancers and poorly differentiated tend to involve the PI3 kinase AKT pathway a little bit more, with PI3 kinase mutations in follicular, some in anaplastic, P10, and so on. And so we'll go over this a little bit more later, but the new drugs that are used really target these kinases, or that's the goal. So first I'll talk about differentiated thyroid cancer, the most common. The risk factors include radiation exposure. That's the main, so like smoking causes or is the most identifiable risk factor for squamous cell carcinomas before HPV, of course. Radiation exposure is really the most identifiable risk factor for differentiated thyroid cancer. That doesn't mean all differentiated thyroid cancers are caused by radiation. It's just that we know that radiation can cause differentiated thyroid cancer. So children living in Chernobyl when there was a nuclear meltdown, children who have external beam radiation as a youth where they used to treat acne that way back in the 60s, other types of radiation, you know, like for lymphoma. And it's felt that the younger the age of exposure, the higher the risk. It's actually controversial whether exposure after the age of 15 confers increased risk. There are also some genetic syndromes associated with differentiated thyroid cancer: familial adenomatous polyposis, Cowden syndrome, Carney complex, and a syndrome called familial non-medullary thyroid cancer, which just basically means we don't know why, but if you've got relatives with thyroid cancer, your risk of thyroid cancer is higher than someone who doesn't. So most patients will present with an asymptomatic thyroid nodule, though more advanced patients can present with local symptoms. It's typically a very, it's one of the least morbid solid tumors. Most patients, again, have no symptoms, very low disease-related mortality. But there are some poor prognostic factors, so older age, larger tumor size, the presence of invasion through the thyroid capsule, obviously distant metastases affect prognosis, as does PET avidity on a PET scan. And if you're a male over the age of 45, your prognosis is worse. Regional lymph node metastases, interestingly, does not correlate with overall survival, but it does correlate with local recurrence, because most of these patients, or I should say a large percentage, will have clinically apparent cervical lymph node involvement at diagnosis. If you have distant metastases at diagnosis, anywhere from 43 to 90% of patients will die of thyroid cancer. But as you can see, it's not 100%, and there are some series that have said 43%. So most patients will probably die of something else if they have metastatic thyroid cancer. Differentiated thyroid cancer, I should say. Here's the survival by stage. So as you can see here, 99.5, I mean, almost 100% 10-year disease-specific survival for stage 1, still in the 90s for stage 2 and 3, and even stage 4 has a 10-year disease-specific survival of 68%. So I'm sure you've all seen this in endocrine clinic. No, I mean, typically it's done by ultrasound at this point, but FNA is the standard diagnostic procedure when a thyroid nodule is found. Most thyroid nodules are benign. There's really only a 5 to 10% chance of malignancy. But again, there's some risk factors, being a male, old age or very young age, history of neck radiation, if the nodule's getting bigger, if there's a fixed nodule or vocal cord paralysis, a history of prior Graves' disease, or family history of thyroid cancer. But I just want to point out that up to 90% of women over the age of 70 and 60% of men over the age of 80 have nodular goiter. So most people, as you age, will have some sort of thyroid nodule, and very few of those are going to be malignant. This is a series of FNAs, 600 FNAs, and as you can see here, only 4.7% were malignant, 87.7% benign, 1.6% was suspicious, and then of course insufficient. So how are thyroid nodules managed? Cancers managed. So you do an FNA, and if it's non-diagnostic or suspicious and the patient prefers a limited procedure, then they'll typically get a thyroid lobectomy just to get that suspicious, or if you're done observing, then you can do a thyroid lobectomy. But if it's non-diagnostic or suspicious and it's large with marked atypia, or if it's suspicious for papillary thyroid cancer, or if there's a family history or radiation exposure, then you're going to go on to a near total or total thyroidectomy. Obviously, if it's diagnostic for malignancy and it's at least 1 centimeter, if there are contralateral thyroid nodules, if there are regional or distant metastases, history of radiation or first-degree family member, or older age, then you're going to undergo a total or near total thyroidectomy. But if it's small, less than 1 centimeter, low risk, isolated with no cervical nodes, then sometimes patients will proceed with a thyroid lobectomy. So after the surgery, the postoperative treatment and surveillance are really based on the fact that differentiated thyroid cancer cells maintain characteristics of a normal thyroid follicular cell. So if you all remember, the sodium iodide symporter here, the NIS, is stimulated by TSH. It gets activated and you take sodium and iodine into the cell, and that's how you make thyroid hormone, thyroglobulin. And so what you can do is give postoperative radioiodine. So if you label some iodine with radioactivity, and then you make the patient hypothyroid, causing a high TSH level, or giving exogenous or synthetic TSH, you can stimulate that sodium iodide symporter to take up all that iodine and eliminate the post-surgical thyroid remnant, which can decrease local recurrence because there's no thyroid, and also facilitate long-term surveillance with radioactive iodine scans or stimulated thyroglobulin measurements. Also, theoretically destroy micrometastatic disease, but we don't know which patients benefit. So it requires TSH stimulation. As I mentioned, you can either allow endogenous TSH levels to rise, or you can give recombinant TSH to treat with postoperative radioactive iodine. It's really not recommended for low-risk disease, but it's recommended for select intermediate-risk patients with microscopic invasion or aggressive histology or nodal involvement. It's always recommended for high-risk disease, so patients with distant metastases, large nodes, or residual disease. And that's because even if the patient has distant metastases, you can still potentially cure them, particularly if they're under the age of 55, young patients, with radioactive iodine. It's really the ultimate targeted therapy because no other normal or no other organs use iodine in the body, and you can have some uptake in the salivary glands, but really that's it. So TSH suppression therapy is also used. Again, the differentiated thyroid cancer cells have the TSH receptor on the membrane if they're still well differentiated, and they respond to TSH stimulation, which increases the rates of cell growth. So when a patient is post-operative, if you give super therapeutic doses of levothyroxine, you can lower the TSH levels in the body so that you don't have TSH floating around out there trying to stimulate rogue cancer cells. The levels differ based on the risk of the patient and comorbidities, etc. Obviously, you can have adverse effects of TSH suppression, such as subclinical thyrotoxicosis. And the length of time that you suppress the TSH varies depending on the risk of the patient and their disease status. So what if there's recurrent disease? Surgical resection can be an option, followed by radioactive iodine, depending on whether or not there was uptake on the scan or prior dose that they've received. And if there's more extensive disease and radioiodine uptake on the scan, then you can give radioactive iodine. If you're going to give radioactive iodine, you really shouldn't give IV contrast in the CT scans, because that will saturate all of the thyroid's iodine receptors, and it'll take a while to clear out all of the iodine in the body. Again, this is the treatment of choice, as it can result in complete response, ultimate targeted therapy. Typically, the patients who have the CRs are going to be young patients with very small pulmonary nodules. The other options would be external beam therapy, bisphosphonates, and now we have newer systemic therapies. And sometimes the disease is growing so slowly, it can grow for 10 years and really not need to be treated, just these little lung nodules. You can have the patient undergo observation. And so what we usually do is I will work with the endocrinologist, and the endocrinologist will often watch these patients for years with metastatic disease. Sometimes they send them to me if they're no longer candidates for radioactive iodine, and then I watch them, but we usually follow them together. So again, the thyroid cancer signaling pathways that we reviewed, where there are those mutations, we have drugs that block these kinases that are involved in the thyroid cancer growth and spread, lenvatinib and sorafenib, for instance. We have newer drugs that block the RET tyrosine kinase, selpercatinib and pralsetinib. We have drugs that block the NTRK kinase, and for the patients who have the NTRK fusions. Obviously, there are drugs that block the BRAF kinase, dabrafenib, vemurafenib. Sorafenib was supposed to be a BRAF inhibitor, but it's not. And then MEK downstream, we have drugs that block that. And so these drugs are used in a variety of thyroid cancers as treatment. So I'm not going to go into this unless you want to stay for my 1 o'clock talk. But in differentiated thyroid cancer, sorafenib, lenvatinib are approved for all types of differentiated thyroid cancer. And then if the differentiated thyroid cancer, papillary really, these two, has an NTRK fusion, you can use larotrectinib or entrectinib. And if there's a RET fusion, selpercatinib, a RET inhibitor, is approved. So anaplastic thyroid cancer, as I mentioned before, is very rare, 1 to 2 cases per million. If you see a case, you won't forget it because it's pretty horrible. Fortunately, most of the patients, fortunately, you're only going to see maybe 1 case in your whole career, if that. It's very aggressive. Median survival is 3 to 6 months, if that. Most patients will present with regional distant metastases at diagnosis. And as I mentioned before, papillary thyroid cancer really has a less than 10% disease-specific mortality. So most patients with papillary thyroid cancer are going to die from something else, whereas anaplastic thyroid cancer has a nearly 100% disease-specific mortality. They'll usually present with symptoms related to this rapidly enlarging neck mass, pain, airway compression, difficulty breathing. They can also have constitutional symptoms. Diagnosis is made by FNA or core, and then you do imaging studies. As I mentioned, most patients will present with at least local regional metastases, but often with distant metastases. As I also mentioned, all of these patients are stage 4, 4A if it's localized, 4B if it's locally advanced, and 4C if it's distant. And this is just a table of median survival. So even for the patients who have disease confined at the thyroid, the survival is 9 months. There's a modest 5-year survival rate. Local extension, the survival is about 6 months, but if there's distant metastatic disease, 5-year survival is really not heard of in most cases, and the median survival is about 3 months. And I also want to point out that this series included 261 patients, but they only included those eligible for surgical resection who lived at least 1 month. So that omitted 203 patients. So really, the median survival overall for these patients is much less because they had to omit 203 patients who could not have surgery and did not survive a month. So with this horrible cancer, the goals of therapy are obviously quality of life and symptom management, end-of-life care, preventing asphyxiation. Death is most often caused by airway compromise, and unfortunately, no therapy has really been shown to improve overall survival. The reason I wanted to spend a little bit more time on this is just in case you see a case. There was a study that looked at rare tumors with the BRAF V600E mutation, and there was a small group, but for anaplastic thyroid cancer trials, this is a pretty big group, 16 patients who all had prior radiation, 6 of whom had prior systemic therapy. And what they saw was a 67% response rate in these patients with some complete responses. No complete responses based on independent review, but excellent responses compared to anything that we had prior. And this is called a swimmer's plot, and this is a waterfall plot. And essentially this shows that if you look, these are ongoing responses. So this patient who was felt to have a complete response, it was still ongoing after 100 weeks, 110, 120 weeks. So these responses, partial responses, stable disease, were pretty durable, certainly compared to anything that's been seen before, with a large number of patients who actually had good responses to treatment. So BRAF testing for anaplastic thyroid cancer is very important. As I mentioned earlier, only about 25% will have a BRAF activating mutation. There have also, RET fusions have actually also been seen, so I would recommend full molecular profiling for pretty much all thyroid cancer, but in particular anaplastic, where our treatments are so ineffective and limited. And I'll just fly through that. I just want to spend a couple more minutes talking about medullary thyroid cancer. As I mentioned, it's a tumor of the C cells. 80% are sporadic, 20% are familial and associated with the ME and type 2 syndromes. They usually present with a thyroid nodule, but up to half can have cervical lymph node involvement. You can also have systemic symptoms, particularly if they're distant metastases. These tumors will often secrete calcitonin, which can cause diarrhea. Facial flushing can also cause a Cushing syndrome if it's secreting ACTH. Here are the MEN2A and 2B and another syndrome called familial medullary thyroid cancer. All of these are associated with activating germline point mutations in RET. 100% of patients with MEN2A and 2B and obviously familial medullary thyroid cancer will have medullary thyroid cancer, pheochromocytoma as well. And then the other syndromes differ, but I won't get into that. And usually we used to check calcitonin levels and follow those in kindred, but now they're screened at birth for the point mutations in the RET proto-oncogene. So you do the staging with the imaging. You also want to screen for pheochromocytoma, and all patients should have germline testing for the RET mutation because family history can often be misleading. Actually, 8% of patients with what is felt to be sporadic medullary thyroid cancer end up having a germline mutation. And then calcitonin level can be a tumor marker. So the prognosis depends on the postoperative calcitonin doubling time, and I won't get into that. This is a surgically managed malignancy. It's only cured by complete resection of the tumor and lymph node mets. They need to have a total thyroidectomy because 30% can have bilateral and multifocal disease. You start levothyroxine immediately postoperative. These are cancers that are derived from C cells, not follicular cells, so they are not TSH responsive, and so you want to maintain a euthyroid state and don't use radioactive iodine. So if they have residual or recurrent disease, sometimes if it's just local, what we see a lot is a patient had suboptimal surgery the first time they were treated, and so they might just need a new neck dissection and they can still be cured that way. There's no real data for radiation, but it could prolong disease progression interval. Traditional systemic chemotherapy has not been effective, but now we have a couple of drugs, vandetanib and cabozantinib. These are multi-kinase inhibitors that are approved for advanced progressive or symptomatic disease, regardless of whether or not there's a RET mutation. Then these new selective RET inhibitors are on the horizon, and one has actually been approved for RET mutant medullary thyroid cancer. And I would say at this point, this is the best option for patients if they have a RET mutation because the side effects are very low, and for patients who've previously not been treated or previously treated, the response rates are very high.